Please take your seats. We're ready to start this next session, which is the presidential address. My name is Husam Balkhy. I'm at the University of Chicago, and I'd like to welcome you, ladies and gentlemen, to Athens, to this International Society for Minimally Invasive Cardiac Surgery meeting. And it is my distinct honor and pleasure to deliver the introduction for the presidential address. Our president is Nikolaos Bonaros, who in this picture was still Nikolaos Bonaros, but not the way we know him now. He was born in Athens, Greece in the mid-1970s, I will say, to his father and mother, Stratos and Panagiota. This is a picture, the only picture I could get of his mom and dad with his sister Rania at the time of his graduation from university, so we kind of flashed forward, but we'll go back to his childhood. I wanted to introduce his parents first. His father passed away, who was an insurance broker, and his mom is with us today and lives in Athens and had previously worked in government, and you can see them here in this picture. Nikos grew up in Athens, and as you can see here, he was a young, very, very interested in sports child who was very congenial and apparently got on very well with his siblings. In this picture, with his sister. He grew up in Athens with hobbies such as basketball, and on the coast, it's hard not to get out on the water. He went to school in Athens, and here you can see a picture of him sailing in the high waves. And at a very young age, Nikos was extremely up for the challenge in these high winds. I don't know that I would be on a sailboat on those conditions. Soon after he finished his studies, he went to study medicine at the University of Ioannina, and had his PhD degree at the University of Vienna with Professor Wollner. He did his residency at the Vienna General Hospital, University Hospital of Innsbruck, as well as a second-level master in minimally invasive cardiac surgery at the University of Pisa. This was not enough for Nikos, so he went on to get a master's degree in health economics at the London School of Economics, and then went on to do translational research on myocardial regeneration in Vienna, and as well at the Surgical Research Lab at Columbia University in New York. So Nikos is a very high-achieving young man at this point, and is basically accumulating a lot of knowledge in various different curricula. He was able to do some extracurricular surgical training at the Cleveland Clinic, at the University of Maryland, San Raffaele Hospital in Milan, and the University Hospital in Zurich. So he had a really broad and wide range of cardiac surgical training throughout his younger years. This is him on the left there with his second-level master's degree in Pisa, with some of his colleagues at the time, and then at the health economics at the London School of Economics, his master's in science there. You can see him in those pictures. He was always very active with summer activities as a student. He was always fishing and harpooning. This is him at the Asian island, basically catching octopuses on the right side there. And on the left, he's trapping with one of his friends who is an ENT surgeon at the current moment. Nikos tells me that he had a great time in the United States. He is a very, very accomplished basic science researcher, and did a lot of great work at Columbia University at the Surgical Research Lab, inspired here by the George Washington Bridge from the 19th floor of Columbia University building. And he was in the lab of Silvio Itescu in the transplant immunology lab, as well as doing cardiac surgery research with Craig Smith and Mehmet Oz, where he was ligating LADs in rats and injecting human progenitor cells to see how he could regenerate myocardium. So those are very, very serious cred in basic science research. During his time in New York, he did not forget to have a good time, and you can see him here at the National Gallery and in front of the Empire State Building, and had some great experiences in New York. He did not suffice with the East Coast of the United States, but also went to the Midwest, and you can see him here in Chicago. To the left, he's at the Sears Tower next to a picture of one of his favorite basketball players, our own Michael Jordan from the Chicago Bulls. In addition to visiting Mayo Clinic, this was a couple of years later, and working with Rocky Daly in the lab. And it turns out that Rocky Daly and the Mayo Clinic team in 2010 were the first to place neocords in the lab, and Nikos was part of those early experiments. Fast forward to going back to Innsbruck, and his mentor, Johannes Bonaros, past president of our society, and here's a young Nikos and a young Johannes basically braving the waters of early robotic cardiac surgery, in addition to bracing the weather during a snowstorm in Innsbruck. And I think this is one of Nikos' first experience with trying to dig out his car from the snow in Innsbruck. Here's some pictures of Cleveland Clinic buildings, one in Cleveland and one in Abu Dhabi, which he visited in 2016 and had an influence on his appreciation of programs and how to run them. A big thing happened in 2007 when Nikos met his wife Sonia, who was a cardiology nurse, and this was during his cardiology rotation. They met allegedly over a patient on the ward who was apparently in hypertensive crisis, where he gave her an order to give antihypertensive medicines, but she wouldn't carry it out. And he told her that this medication dosage was correct, but she really didn't listen. And eventually he convinced her that the medication was correct and that he was the correct guy for her. And she ended up accepting his offer after they dated, and they got married. They went on to have 2 children, Larissa and Julian. And of note, Sonia is here with us on the first row here, and Larissa and Julian are both here as well. Larissa is 15, and there's a picture of her as a baby surfing on the coast in Athens. And Julian, who is now 12, is there skiing with his dad in Austria. The Bonaroses enjoy the mountain life in the Alps during the summer, and you can see here some great pictures of the Austrian mountains, and also enjoyed the different landscapes. This is again in the winter in the Alps, but they also enjoyed the landscape in Athens, where they summered frequently. This is some other activities that Nikos engages in, which is cycling. He's well known to be a biker or a cyclist, and he cycles to work every day in Austria, no matter what the weather looks like. He's on his bike going back and forth from work, regardless if it's snowing, which is the picture on the right bottom there. And as I said, they enjoy the summer vacations in Greece, which is a different vibe, if you will. So it's great to have all of those different activities at your fingertips. I'll quote Nikos with some of his own words in this introduction. He identifies himself as a person empowered by a fantastic family who likes setting goals and pursuing them with determination and empathy. And what counts most to Nikos is the achievements of his team, which he supports on the basis of bilateral loyalty and trust, and a prerequisite of overall success for individual team members. You can see him here with some of those achievements in the arena of life, whether it's hiking with the family, or swimming in a lagoon in Hawaii, or playing soccer with the Austrian team at the European Association of Cardiothoracic Surgery. You'll see some faces there that you probably can recognize. It is always with gusto and with a competitive and goal-driven spirit. Nikos is no stranger to leadership positions, whether it's local or international. He was a deputy chair at the University Clinic in Cardiac Surgery, A2 professor with qualifications in minimally invasive surgery, and a director of clinical programs, as you see here, as well as the PhD program in cardiovascular medicine at the Medical University of Innsbruck. International leadership positions include this one, where he has been on the board of the International Society of Minimally Invasive Cardiac Surgery and a chairman of the working group of the European Society of Cardiology, a task force leader at EACTS, and a course director for Focus Valve, which is kind of his baby at this point. This is a slide that he didn't want me to show, which was compiled by one of his research residents that gives you all of these things in a one captured slide. I wish I had a research student that would do that for me. Maybe I don't have enough things to fill the slide, but this is a telltale of all of Nikos' achievements. Here he is showing his clinical mentoring for the future generation of surgeons at the Department of Anatomy course for young cardiac surgeons, which he frequents a lot and teaches the younger generation. And this is the Focus Valve meeting that he runs every year in Innsbruck and brings students and residents to this in order to get an early jump start on cardiac surgery. In terms of other activities at societies, he's a big factor at the Guidelines Committee at the ESC-EACTS and was also a part of the Robotic Cardiac Surgeons Society at ISMICS previously. And he's kept up with all of the changes and evolution in training and mentoring, and here he is using this new technology called rods and cones and doing remote proctoring for endoscopic mitral valve surgery at a recent case. So without further ado, I would like to introduce to you our president for the 2024 International Society of Minimally Invasive Cardiac Surgery, Dr. Nikolaos Bonaros.
Wow. Sam, ladies and gentlemen, as a rule, when I'm attacked, I can defend myself. But when I'm praised, I'm helpless. So Sam, I have a very hard time now. This is not my quote, this is a quote of Sigmund Freud, one of the most famous Austrian doctors and philosophers, and comes as I really feel overwhelmed being your president for the whole year. The presence of all the members here, all the old, new members, friends, makes me really overwhelmed. It has been an enormous honor and very fulfilling to me, for me to serve as ISMICS and you as the president. Imagine you're sitting in a quiet room reading your favorite newspaper. All of a sudden, you look up at the ceiling and you realize something is missing, just a tile. Now tell me, what do you look out for? Room, newspaper, what are you doing? No, of course, the missing tile. Ceilings are good because you can replace it. Somebody replaces it and gets a perfect ceiling for you. Ceilings, after all, can be perfect. But this is not what applies to life. Life, satisfaction, consists of many, many tiles which are never fulfilled by 100%. And first, we know that my missing tiles are very, very different than yours, aren't they? So I think that most importantly, any tile missing in your life, or what we think is missing, cannot be replaced. Unlike a ceiling, life can never be made perfect. For that reason, concentrating on missing tiles in our life may be a big problem. Psychology uses a term called the missing tile syndrome. Then why do we have this natural built-in function at all? The answer is obvious, because we want to ensure that our long-term quest to improve our life is there. So now, how about medicine? Well, here the condition is similar to our own lives. Patients come to us because they want to fix their missing tiles, sometimes just a single one, occasionally several of them. This is the case for this severely symptomatic ischemic heart failure gentleman. Very bad ventricle, regional wall abnormalities, severe mitral regurgitation, etc., etc. One could argue in this case, if there is one or several missing tiles here, every one of us is sure that this patient will be recommended the one or the other procedure according to the perspective of the surgeon standing in front of him. The coronary surgeon that, for example, suggest a coronary artery bypass grafting. The mitral surgeon we're going to say, okay, let's do mitral valve repair or do a tear in this patient. The heart failure surgeon was going to say, we opt out for a assist device or cardiac transplantation. This means that even in science, in which we spend millions of dollars and euros to get as much information as possible, to take informed decisions, the missing tile is a matter of perspective. And we all agree that this perspective is not the same all the time. Sorry. Now, I will take you to a journey, to my journey, to be more specific, to tell you about my missing tiles in medicine. I spent my first post-promotional years, as Sam said, as a young doctor at the University Hospital in Vienna. This was a 52-year-old patient with a history of CABG and surgical ventricular restoration surgery at the apical site, presenting with an acute or chronic heart failure. The condition was complicated by a history of lymphoma precluding heart transplantation. So the therapeutic options, of course, in this case are very, very limited. And there is a huge missing tile affecting not only this specific patient, but millions of others too. Which one? The fact that the heart cannot regenerate itself. So the hope that the myocardium regenerates after myocardial infarction, definite cell death and fibrosis, has been shown to be an illusion in the human heart. Are there any fish fans here? Anybody fishing? Oh, here, a couple of them. This is zebrafish. The little tiny guy has a body length of less than 5 centimeters. He has a 2-chamber heart. If somebody cuts the apex, please don't be afraid, nothing happens. That's for you, Julian. The heart is regenerating. There is an instantaneous clot formation. It covers the wound. It stops bleeding immediately. And the story goes on. There are cells within the epicardium. They start to proliferate and build a new outside layer, which engulfs the whole scar. In addition, satellite cells are migrating to this area, proliferating, and all of a sudden, a couple of days later, this little tiny guy has a new apex. So it takes between 14 to 100 days, and this guy swims back. So why is it not possible to do that in humans? Not until now, unless we will be able to reprogram myocardial cells to fetal state and allow de-differentiation and reprogramming, which enables cell cycling re-entry and facilitates heart regeneration. I tell the story because I also started working with these several types of adult stem cells, starting improving left ventricular function after myocardial infarction. But this was partially effective. I also failed in the real infarct zone, and not me, but even much more important laboratories and a lot of scientists. It was therefore evident that isolated stem cell injections would not suffice for a clinically relevant effect on myocardial regeneration. Hence, we decided to improve the conditions of survival and differentiation of the injected cells by manipulating the myocardial milieu. We then came across of a neuropeptide. This is called secretinurin with potent anti-genetic characteristics, which both as isolated injections or in addition to progenitors reduce fibrosis and ameliorated left ventricular function. But survival of the transplanted cells within the scar still remained the limiting factor. As a next step, the lab of Johannes Holfeld in our university, we decided to stimulate endogenic mechanisms of repair with what I call producing stem cells from the electrical outlet. Then we use directly epicardial shockwave treatment. Perhaps you know this treatment. We use it to treat kidney stones, lithotripsy, or even nowadays vessel calcifications for TAVI or joint abnormalities. So we could demonstrate that it would improve heart function after MI. And how does this happen? By mechanotransduction, which means that a mechanical stimulus induces a biological response which under specific conditions activates reparatory mechanisms in the myocardium. And I'm really proud, and we're really proud of these people of the research lab for this outstanding work. And as we were able to achieve impressive results in the lab, we moved to the CAST-HF trial, which was the first prospective randomized clinical trial testing the effect of shockwave therapy during conventional surgical revascularization. And the study, you see here on the left-hand side, a reduced left ventricular function, dilated ventricle, how it develops by using a combination of coronary artery bypass grafting and shockwave therapy with an impressive increase of 12 ejection fraction percentages. The second missing piece that came to my mind after entering cardiac surgery was the maximal invasiveness of cardiac procedures and the limited opportunities to use real keyhole techniques. I'm sure that this missing piece of the jigsaw is something I share with a lot of you, because this is the reason why it brings everybody to us, to Athens, under the big ISMICS umbrella. 30 years ago, the American College of Surgeons set the frame of evaluation and credentialing of what was called emerging surgical technologies, mainly meaning minimal invasive techniques. The principles apply perfectly to the current situation. Development of a new technology must be accompanied by a scientific assessment of safety, efficacy, and need. It was told 30 years ago. This means to me that the ability to do a procedure does not entitle me to do it without a clear indication. Second, I need to assess the results, and the assessment should cover well-monitored observational and controlled clinical trials. As of the early 2000s, we set a goal to transform our cardiac procedures to a limited incision platform and increase adoption by all team members. What you see here is the almost unanimous adoption of minimal invasive techniques for the aortic valve, which makes our residents understand that a small incision is the default procedure and full stenotomy is done only if required. We have also evaluated the differences between the conventional stenotomy, an expert's approach, mini thoracotomy, and even a more versatile limiting incision technique like mini stenotomy. By allocating patients according to their anatomy, we could further increase the safety. And by adding the totally endoscopic approach 2 years ago in selected patients, we could abolish major complications. The next bastion was the mitral valve, which per nature requires a substantial foundation of diagnostic and technical expertise. You can recognize how the program was increased by starting a mini thoracotomy program 22 years ago and progressively establishing a non-full stenotomy approach by 2010 and a fully 3 endoscopic approach 10 years ago. Again, this is not the end of the story. We go back to the statement. Throughout this period of time, 7 surgeons underwent in-depth training for the mitral valve, contributed to the further development and adjustment of the procedure from a narrow patient selection to almost an all-comer basis. So there's another issue pointed out at this statement which refers to the evaluation of new add-ons. A quality improvement program was done, and we assessed the addition of 3D endoscopy, the use of pre-measured loops, compulsory use of a preoperative CT scan for every patient, and you see that you go down with a complication, 0 mortality for the last 850 cases. At the end of the day, we need to be able to evaluate the appropriateness of treatment, which refers to the information we provide to the patient before surgery. Saying I can fix your mitral valve through a tiny incision is not appropriate. We need to say I can fix your mitral valve through this incision with a 90% probability of freedom from stroke and mortality. This is what we want to say. And this was shown by an extraordinary, by the way, quality registry comprising more than 7,000 patients by Marco Di Iusanio and Paolo Beretta. This brings us to the value of indication for treatment. Being hosted at my home country and the home country of Hippocrates, there is no better way to highlight the importance of collecting information for decision making. Hippocrates says, "I omnia, I anomia ex archis." First, discriminate by using observation. Search for signs of disease, and then, a ignoscomen appas in est ignone. Finally, use all sources of knowledge to get to treatment. Back to the missing jigsaw pieces. More interesting than mine are those of the next generation of cardiothoracic surgeons. I intentionally asked this question to our residents and fellows in our university. The answers were quite surprising for me. That was the top response, namely the battle between technique and technology. What those people eventually say is that when they ask the most experienced ones, which part do I need to master to become a good surgeon? Half of them tell them you have to master a technique because surgery is an art. Surgery needs dexterity, this makes a difference in outcomes. The other half says technology will solve all technical issues in the future. Simply learn how to use it, period. The perspective of a surgeon as an artist is old. We all recall the work done by Leonardo da Vinci, a master of his art. More typical, perhaps, are many surgeons who have an active interest in art, also practicing as painters or sculptors. One such example is Donald Sammet, a very interesting website. Please visit it. He's a consultant hand surgeon based in Bath in the UK, who has developed an impressive portfolio of anatomical and pathological paintings and drawings. He emphasized that surgery and art are profoundly intertwined. Just a drawing is about seeing more than about execution, so is surgery about listening, diagnosing. Surgery is an intellectual, not a technical exercise. There's a huge component of surgeons' manual dexterity to the overall results of the patients. We all know surgeons who complete procedures in a short time who have no or minimal complications. Surgeon A goes to the OR, the whole team is happy. They know that this person is going to do that without any problem. And Surgeon B comes, everybody's holding the head. Oh my God, we're going to see today. So this is probably a small proof that surgery is an art. The surgical treatment of a patient with a prosthetic valve endocarditis, aortic prosthetic infection on top of that, third-year operation setting, will always remain an intellectual and technical challenge. Removing all the infected material, creating a pericardial tube requires precise movements, very exact stitches to avoid twisting and distortion of the neo-aorta and allow a safe landing zone to the bioprosthetic root. This is a typical procedure requiring experience and extensive mental preparation and manual dexterity. But the same is true for a transcatheter valve-in-valve implantation in a degenerated 21 rapid deployment valve performed by Dr. Kraft. He's here in the auditorium, which officially actually is considered to be unfracturable, this valve. If you go to the app, it says unfracturable. The exact placement of the new valve and fracturing of the upper part of the valve is a matter of thoughtful conceptualization, advanced technical dexterity, which leads to improved functional outcome. Needless to mention that this technique of valve frame fracturing of conventional bioprosthetic valves was developed by an ISMICS member and presented at an ISMICS meeting. So anyone who wants to treat a patient should first become an expert to acquire in-depth knowledge and skills, and this goes along with practice. This is Williams Halstead. He says that practice is traditionally acquired according to the principles of intense and repetitive exposure to the task, ensuring a complex integration of a cognitive knowledge with manual dexterity. So not only know the technique, but also own the technique. If we want to simplify this, it is learning by doing, concept of creating expertise and competence. Apart from the need to be performed by an expert, the technique should be also reproducible. Reproducibility is the likelihood of achieving the same result by using a specific technique by a high number of surgeons. We could discuss for hours if the classical Carpentier techniques are of course very, very effective in treating the disease, but I don't know if they're reproducible in all hands. Here I show you another technique, treating the same leaflet pathology using artificial chordae with a simplified loop concept. This technique is definitely more reproducible for the majority of the surgeons, and it breaks down a complex task to smaller standardized parts, thus minimizing the risk of error. Moreover, it allows for more and more complete treatment of the pathology by evenly distributing forces. But how did this evolution of a technique happen at all? The answer is through technology. On the left-hand side, you see the mitral valve analysis via stenotomy, and on the right-hand side, you appreciate what I call valve microscopy, 3D endoscopy, which gives you the opportunity to delve into the nature and composition of every single primary chord and identify areas of risk. So you can see the difference in the picture of the primary operator left and the assistant now. This guy never sees the anterior leaflet. So how can this person be taught after all? In this case, we may have a reproducible operative technique, but we don't have a reproducible knowledge transfer. And training for a simple reason, why those two persons do not have the same picture as opposed to a 3D endoscopic procedure. Here, the operator and the assistant look at the same monitor, and if the view of the assistant is obstructed, so is the view of the operator. The other advantage that technology adds in this case is to optimize the trajectory of working instruments to the mitral leaflets, and most importantly, to the subvalvular apparatus. So it adds ergonomy and makes it easier. Another illustrating example is of the interaction between technique and technology is the surgical treatment of hypertrophic cardiomyopathy. Most surgeons rely on the extensive Morus myectomy, which addresses the proximal part of the septum, and you can see there is no doubt there's an adequate myectomy, especially in patients with asymmetric HCM, and it restores flow and the left ventricle outflow tract. But contemporary imaging, including TE, shows us there are other problems here. For example, the mitral valve in patients with concentric, symmetric, hypertrophic phenotype and systolic anterior motion of the anterior leaflet. Here again, the technique of meticulous identification and resection of the hypertrophic secondary chords or of the aberrant muscle bands are essential for the treatment. Robotic technology not only has enhanced visualization of the pathology, but also opened up new opportunities of totally endoscopic treatment of a very complex pathology. In this video, thanks Sam, you may appreciate how technology enables the detachment of the anterior leaflet, the resection of the pathological secondary chords and bands, and the performance of an extensive and more complete, more deep myectomy. Even the augmentation of the anterior leaflet can be performed there. The missing pieces here, obviously, relates to the immaturity of preoperative imaging and surgical instruments. And talking about surgical instruments, further developments are expected since the first generation of real transcatheter instruments are already in the pipeline. This is an example of an intracardiac needle holder, which can be used for tissue suturing of intracardiac structures. The needle moves on rollers, which gently pass into the tissue precisely and by following the curve of the needle. Everybody of you has heard this sentence millions of times in your life. Follow the curve of the needle. The combination of mechanical refinements on smart instruments with the ability to recognize tissues will ignite the possibility to perform remote access beating heart cardiac surgery. Back to our residents and fellows. The second point they've made, why do we tend to ignore data we already have? And I will tell you in a minute what I mean. So those are, you see here, the troponin levels of 2 patients after coronary artery bypass grafting, demonstrating a rise more than 150 times higher than the upper reference limit. What is it? Myocardial infarction. The patient on the left has, in addition to a new complete AV block in ECG, and the coronary angiogram revealed a block of a stented right coronary artery, older stent, which was not addressed at CABG surgery. On the right-hand side, you see another patient, the same levels of troponin, no ECG abnormalities. The patient underwent coronary angiography according to our internal standards because of the high troponin levels, which did not show any graft pathology, open graft, everything okay. So both patients would have qualified for a perioperative myocardial infarction according to the current definitions. But is the prognosis of those 2 patients the same? There are definitions which rely on solid troponin levels, like the ones in blue, and definitions which need ECG or imaging evidence, like the ones in gray. You can see there are huge differences. And you may recall exactly the topic raised a never-ending discussion regarding the Excel trial, which led to a BBC investigation, the withdrawal of EACTS support from the revascularization guidelines, and downgrading of PCR for the left main disease thereafter. Huge discussions for years. Leo Pölzel and Can Goldman from our group could prove that any cardiac operation on cardiopulmonary bypass and cardioplegia is associated with release of troponin. That's common knowledge. But they could demonstrate that the latter does not have an impact on outcome, which you see on the blue mark definitions, unless the patient has signs of ischemia. This relates to definitions marked in gray, which are associated to a more than 5 or 2-fold increase in the risk of MACE and death, respectively. Moreover, they could demonstrate that cardiac operations associated with major manipulations of the ventricular myocardium, such as CABG, on the arrested heart, are related to a higher troponin release than procedures which involve a sole aortic access like an AVR. This is a new finding that shed light to the discussion. At last, a lot of experts on cardiac biomarkers thought so. This paper of Hartzell-Schaaf is exactly 40 years old. You will be surprised what it shows. The authors compared patients' complicated perioperative myocardial infarction, meaning patients with ECG and echo abnormalities. They didn't have troponins back then, they did just have CK, CKMBs, and they compared those with patients with a CK, CKMB enzyme release. The study could demonstrate, guess what? That only complicated perioperative myocardial infarction has a high impact on mortality, whereas mere enzymatic release makes no difference. And I ask you, why did it take us 40 years and tons of literature and discussion to accept this obvious rationale? The answer was also given thousands of years ago, because people willingly believe what they wish to be true, and we all do. What was the missing piece in this case? An inadequate critical appraisal and typical stroma fallacy. The last part of the discussion, I will take you to I guess we have reached a point that we all agree. Although we have gone a long way, there are still several missing pieces in the jigsaw. I'd now like to take you with me in a new reality where we do not have any lost pieces anymore. To do that, we need to leave the gray zone and little issues of our microcosmos and watch the scenery from above. ISMICS is a big hub for people interested in minimally invasive surgery with different levels of experience. So I will start with the most experienced and the artists among you. Looking at this picture in the middle, the majority of you will recognize a lumbar spine X-ray. Some people in the audience who have no previous experience with X-rays of this type, they would recognize some different Scotty dogs. The most experienced among you, we will not miss the fracture on the upper spine at the pars interarticularis, which less experienced people could probably recognize as nice colors along the neck of the dogs. This phenomenon is called pareidolia and illustrates the fact that even in medicine, we not share all the same picture of a finding. So ladies and gentlemen, now it's going to be tough for you, for the most experienced ones. There's only one way to get the same picture, and this is sharing your vast experience with other younger people and teach. It doesn't matter if you are the only expert in the country in mixed CABG or vasculobectomy, or if you have done 1,000 similar procedures and you want to reach 2,000. It doesn't matter, a note from myself, if the patient is referred to you, if the next case waits, if you have an appointment with a hospital director. All these excuses show that we have not understood that our impact will only be magnified if we give our experience to the next one. And we have to keep in mind two things. Skills can be taught, we know that, but there are different levels. The cognition, the integration, and the automation, which all moves brings us to the expertise. At the end of the day, the learner no longer needs to think about how to execute this particular task and can concentrate on other aspects of the procedure. Expert performance represents the highest level of skill acquisition, and the final result is gradual improvement through extended experience. And you can do that not only by simply practicing, but also by deliberately practicing. You can recognize this guy. This is deliberative practice. He has the target. He has a name. He wants to own this technique. He tries to improve himself. On the other hand, patients come to hospitals for treatment and not to aid education. And patients' safety and quality of care priorities far outweigh clinical training requirements. Therefore, we are responsible to create a teaching environment for our residents and fellows at different levels. This is an example how I have learned arrested and beating heart TCAP simultaneously to my training in conventional coronary surgery. And in case you think this is risky and expensive, think of a pilot sitting in a cockpit of a $65 million Super Hornet who lands onto a $13.3 billion air carrier with 4,500 people on board. This person has an average age of 23, has finished a training of 18 months to earn the wings, an additional 6 months to learn how to fly an air fighter. To the mid-career surgeons, if you really want to move to minimal invasive surgery, you need to go to the simulator. This is our responsibility for the patient, and sooner than later, it will become medical board prerequisite. I prognosticate similar tables to be created for surgery too, and nobody of us wants to be the guy with more than 3% complications. There are amazing opportunities nowadays to train not only common steps, but also the specific valve with a specific pathology we want to repair tomorrow morning. There's an excellent simulation course by Payman Sardarinia. This means that you go to the OR to do an operation which you have performed into detail, even several times the day before. You know which problems are expected and how to manage it. Another important point, minimally invasive cardiac surgery is a school for life. Do not be afraid to start with minimally invasive procedures, even at the beginning. This is the first AVR case of one of our fellows using mini stenotomy to access and replace a degenerated bioprosthetic valve. Going back to the learning models, it's all about cognition, conception, as technical skills are given. Use a versatile approach for the beginning, and having somebody to guide you and get you out of troubles is essential and brings you up to the next level. During this journey, you will encounter difficulties. I couldn't even see this annulus in this case. So you have two choices. Either you give up and go back to stenotomy, or try to optimize your chances. And this is chances optimization. The reason we have stopped thoracotomy AVR and jump to a more reproducible endoscopic concept gives you the opportunity to move your eyes within the thoracic cavity using the scope. You can now appreciate the view you achieve of the aortic annulus and the versatility of other ports in this case. Last but not least, 3 messages to the most important persons among us, the early career surgeons. In the age of instant information and quick solutions, there is a growing inclination to seek shortcuts to success. This trend poses a significant challenge to true mastery. In a world where AI is reshaping industries, becoming a specialist and mastering a trade is more crucial than ever. Easy solutions can be tempting, but with the rise of AI, the landscape of medicine will change. Generalists will be replaced by AI, and the value of in-depth expertise will become more evident. One could not explain the basic surgical principle better than Theodor Billroth, one of the most important Viennese surgeons. First start talking to the patient, then prescribe medication, and then at the end take the knife. So identify a field that aligns with your passion. Mastery requires, of course, dedication and passion, and this fuels your commitment. Embrace the learning curve. Mastery comes with a learning curve which can be shortened by training models. And again, do not rely on shortcuts. The world needs more builders, not borrowers, more creators, not copymasters. Go forth, master your craft, and leave your own mark, not with the footprints of a shortcut, but with the powerful strokes of your own journey. Training is important, But the most important time in your career are the first 5 years of clinical practice. They are decisive on whether you belong to the category of the expert surgeons and the green ones, or strive to go to mediocrity and dropouts. This happens at the first 5 years. To achieve that, you need to find a mentor. Training is a traditional way to learn, and it is followed in medicine. Lawyers follow it, and musicians follow it. The contrast in view comes out of sports. They say you're never done. Everybody needs a coach, even the greatest in the world. And there's a very good example here. The Harvard-Yale football rivalry started in 1875, and it's renewed annually with a game, an American college football match between the Harvard University Crimson team and the Yale University Bulldogs. In 1876, Yale came up with the idea to hire a coach for the team. Harvard did not. The result is here. Over the next 3 decades, Harvard won just 4 times. What happens next? At the end of the day, Harvard hired a coach. In my life, I was lucky enough to have important personalities who have mentored me. And the reason I'm allowed to stand here is because I stand on their shoulders. Johannes not only lit the fire for robotic procedures, provided a vision and helped me set targets at several steps in my career, but also guided and learned me how crucial a systematic approach and checklists are. Alfred forced me to go out to the OR. He kept telling me, you don't need to get out 1,000 veins. Go to the lab and learn understanding what you're doing in surgery. Ludwig told me dozens of techniques, thinking before every single stitch. I owe him the enthusiasm for minimally invasive surgery and my passion for the mitral valve. Michael, apart from spending hours in discussing really tough patients and cases which have been refused by other centers, he always reminds me that the most important beneficiaries of the department after the patients is the next generation of surgeons. There are additional reasons I feel privileged and lucky, and this refers to this meeting. I had the opportunity to work with an extraordinary people team taking care of an extraordinary program, which I hope you enjoy and you will be able to follow up to Saturday. Both the cardiac and the thoracic senior and junior program directors have demonstrated an incredible energy and commitment in order to maximize the learning effect for you. I'm really grateful to you, Sabine, Antonis, Robert, Johannes, I don't know where you are, as well as Andrea, Felix, Rainbow, and Antonis for serving as program directors 2024. This is the ISMICS family with an incredible administrative support. Rob, you are not the administrator, I know. By our executive director, Orly Olger, and her team, including Stan, Sheila, and Yvonne, and many others, taking care of everything running behind the scenes. Your work becomes even more visible if you see the people singing here around. Where is Orly? Here. Please come on. The next person I would like to especially highlight is Britta. Britta Tyler was the main engine behind the meeting organization. Without her day and night work, this meeting would not have reached this level of success. So Britta, come over. Besides the administrative, there is a scientific team dealing with the strategic decisions of the society. I would like to take the opportunity to thank every single member of the board of directors, consisting of real masters in minimally invasive cardiothoracic surgery and key opinion leaders in the field. I hold the utmost respect and admiration for the 6 members of the Executive Committee of ISMICS, Sam, Gri, Nirav, Vino, Jörg, and Abbas, all of whom contributed to this year's very good success. Until now, I have let a lot the brain to speak together with my heart. Now we'll focus on the latter. We are who we are because somebody else sacrificed a major part of the life to bring us up there. Those 2 persons are my parents, who succeeded to pass my sister and me a vision for our life. My father was telling me every night, when you go to bed, ask yourself what you did today to achieve your goal. Unfortunately, he passed away last autumn during my presidency here at ISMICS. I miss him a lot. My mother's motto is related to excellence, and it's not a coincidence, but a consequence of intention, effort, and execution. It's a choice, not a chance. I'm lucky enough to use this occasion and say thank you for all you have done. Σε ευχαριστώ. And then when you're lucky enough to get such a robust foundation by your family, you start your journey in life. And this was the point I became even luckier, to get knowing my shots and get the privilege to become part of your life. You couldn't have done it better. You are the maestro who keeps an eye on everybody's melody and the glue that holds us all together. I love you. We're both lucky enough to have 2 extraordinary children, Larissa and Julian. Like many siblings, you have different strengths, but you have one thing in common. You are trying to become better than your parents, and I'm sure you will succeed. I learn a lot of you. Now, before leaving the podium, I would like to wish you all of you, a marvelous Congress. Enjoy the rest of the meeting, and don't miss the opportunity to go around in the extraordinary city of Athens and join the reception today evening at the Acropolis Museum. Thank you. Thank you. Thank you very much.